Assalamu alaikum and a very good morning to all the participants. We welcome you to the day 2 of the 24th Pakistan Society of Haematology annual conference. We just finished with the Young Investigator Award session and we hope that you all could have joined in for that and have enjoyed it as well. It's now time for our plenary session and it gives me great pleasure to introduce Dr. Catherine Hayward, Professor of Pathology and Molecular Medicine at the McMaster University. Dr. Hayward's research laboratory at the university is involved in conducting bench-to-bedside studies of molecules important to blood clotting and vascular repair. Her group described the first bleeding disorder associated with increased urokinase type plasminogen activator, a condition we all know as the Quebec platelet disorder. Dr. Hayward is supported by operating grants from the Heart and Stroke Foundation of Canada and the Canadian Institute of Health Research. She is the recipient of the 1995 Governor General Gold Medal Award for her PhD studies. Dr. Hayward is the Associate Dean of Graduate Studies and is actively involved in the Medical Sciences Graduate Program as a supervisor of graduate students. She also teaches hematology residents and other postgraduate medical students during their coagulation rotation on topics such as bleeding disorders and laboratory tests. And keeping the momentum alive, her topic for today's plenary session is quality councils as a means to promote quality in the laboratory.
I want to start my presentation by bringing warm greetings from the ISLH leadership. I'm Kathy Hayward, the immediate past president of the International Society for Laboratory Haematology, and I thank you for the honor and privilege of presenting at your meeting this year. I want to talk about quality councils as a means to promote quality in the laboratory. And I'd like to acknowledge the members of our quality team who've helped me prepare the slides for today. A quality management system is a system designed to manage continual improvement of all processes in an organization to meet customer expectations, which in the case of medical care is patients and the other individuals in our healthcare organization that rely on what we produce. The goals and objective of what I will cover today are to discuss the roles of quality councils in quality management programs, to provide perspectives on quality management programs for laboratories, and to give you some illustrative examples of efforts to improve quality in real life in a hematology laboratory. Promoting quality has some key elements. The business management software is really an important part of your quality management system, the accreditation rules that apply in your jurisdiction, and a program for risk management. Our business management software has the nuts and bolts for managing all aspects of our quality management system. The accreditation part is really important for assessing your quality management system and how it functions. Risk management is an essential part because we are always mitigating and managing risks within our quality management programs. And assessing and promoting quality, the quality council component has a really important role in oversight and setting your quality goals, tasks, assessments, and monitoring your achievements. And this is something that needs to permeate throughout your organization for success. The Quality Council oversight has an important role as it is really the driver of our quality management program performance and plans. And the purpose of the council is to foster a culture of continuous improvement, to monitor the program's performance, to develop a program quality improvement plan, and then to oversee the implementation of appropriate and aligned data-driven quality improvement initiatives to share successes and to sustain your improvement gains. In our program, our laboratory quality council members represent multiple stakeholders, and I think that's really important. So some examples of whom to consider engaging in a quality council. We have our discipline managers, professional staff representatives, department laboratory technologists, laboratory assistants, senior technologists, technical specialists, and our quality specialists as well. So a very big team with tentacles out to all parts of our organization. What does our quality council have responsibilities for doing? That culture of continuous improvement is really important. So the team in the council participate as leaders and team members to corporate continuous improvement activities. They develop ways that we promote the acquisition of knowledge and skills to promote continuous improvement. We involve and support staff in their quality monitoring and continuous improvement activities, identify local champions for quality improvement, and mentor them to take on leadership roles. The council is open to new ideas and approaches and has to be action-oriented in order to make achievements in quality improvement. And we have to work collaboratively within and between programs and departments. We also provide peer support to other programs and departments as needed, and I'll touch on that with an example of a quality improvement initiative, and guide activities within our discipline quality teams. We're also working on identifying program-wide organizational development needs and recommendations for training or education programs for our staff. So the Quality Council tasks are maintaining and improving the quality management system, to identify those elements in the system that need further development and improvement, and recommend audits on components of the system when performance is in question, for example, after an external audit. Coordinate and recommend reports for management review that provides a measure of the effectiveness of our quality management system, provide direction to our leads and discipline quality teams for program-wide improvement activities, and then provide direction to meet our laboratory and hospital accreditation as required. The tasks also include the planning and monitoring of performance and quality improvement activities, so things like balance scorecards, dashboards, delivery indicators, utilization indicators, fiscal indicators, quality of life work indicators, and other performance indicators that need to be aligned with our overall organization's missions, values, and visions, and also to develop a strategic map and Accreditation Canada meeting their accreditation standards in our jurisdiction. The Quality Council also reviews and analyzes report on key indicator data and communicates and acts on trends of significance. And we also need to have formal processes to assess the needs of our patients and customers. So things like real-time survey comment cards, internal surveys, and consultation with key stakeholders are how we do that. We need to make sure what we do is sustainable. So the Quality Council has important tasks in ensuring we have ongoing quality monitoring and evaluation of quality improvement. Best practice tools and techniques need to be considered to enable sustainability of our successes. And we need to create opportunities for intra and inter-program department sharing of successes and lessons learned. And in terms of reporting, don't document, not done when you're audited. So we have to think of ways to prepare and present an evaluation-driven report to communicate to key stakeholders as part of the tasks that we do. So practicalities, how do we do this? Our Quality Council meets monthly. We have agendas for each meeting, and each meeting we decide on tasks and assignments for the next meeting. So we've created reported templates for gathering data to be data-driven. We have different tasks and assignment each month, and I'll give you some examples later in my presentation. So we report on personnel needs, documentation of training, quality assessment gaps, And these are all important ways of showing that our program is addressing any gaps in our quality assessments. And we also have broad discussions at our meetings because our quality council is really something that's there to support all of us. So these are examples of some assigned tasks. We're looking at the baby boomer age now starting to retire in big numbers. So do we have evidence that we will have continued adequate staffing for our program? So we, in a recent meeting, asked people to report back on changes to professional staff. And this is an example of the reporting template that we used and the sort of data that we gathered. So identifying when you're going to have gaps, temporary or permanent, that you need to fill and address is really important. We've had other assigned tasks related to training records of our personnel. So we have on our quality management system, we track our training records, and sometimes training records aren't complete, they're open. And so we ask people to report back how many they had open, and at the time of the quality council meeting, how many of those deficiencies they'd managed to complete. Some other examples of assigned tasks are competencies assessment. So in a previous and recent audit of our lab's quality, we were identified as having gaps in our documentation of competency assessments. So for ongoing activities, we ask people to deliver us information on what our current status is. So ask each of the department to give us an update on their competency assessments and the percentage of staff completion that they had achieved, with action items to address when there were important gaps. So your quality management system in organizations, the American Society for Quality defines it as a formalized system that documents your processes, procedures, and responsibilities for achieving quality policies and objectives. And your quality management system is a really key tool to help coordinate and direct your organization's activities to meet customer and regulatory requirements and improve its effectiveness and efficiency on a continuous basis. So in laboratories, and I've got a hematology laboratory focus, quality management systems are really important. They help clarify roles and responsibilities within your organizations. They simplify processes to allow for improvement and reduce the need for rework, provide a process for key performance indicator, structure for your process control, provide a process for continuous quality improvement, and overall guiding improvement for patient and staff safety. And a quality council is an important component of your quality management system. So in our center, our quality management system was designed to support our diagnostic laboratories' mission, vision, and values, and to ensure that our services meet regulatory and accreditation requirements and the need of patients and all personnel responsible for patient care. So those are our customers. To support continuous improvement and customer satisfaction and promote our error-free work and a high quality and appropriate lab services. So systems in place to promote accurate and precise results, appropriate test selection, timely reporting, correct interpretation, clinical usefulness, appropriate recommendations for further tests that may need to be done on a patient. So those are all part of our quality management system. The 12 essential components are what we have in our quality system related to our organization, personnel, equipment, purchasing and inventory is part of it, process control, our procedures for doing different tests, documents, records, information management, occurrence management. If we have an adverse event, actions we've done to investigate and take actions as a result to prevent such risks in the future. other assessments, process improvement, service satisfaction, and also facilities and safety are components. We use a particular business management system at our center to control our documents. In that, we manage our policies, procedures, forms, any methods that are printed out from that system. The process control is that once it's printed out, it's no longer a controlled document. So we have very strict control on what procedures people are following when they're doing testing in our laboratory. There are also procedures for staff hires, for evaluating performance, etc. We have in our system the way that we manage non-conformances and take corrective actions and document them. And we also have in there our records for staff credentials, equipment, and safety inspection, as well as our training and competency records. So really a key part of our quality program. With accreditation, we have in Canada both laboratory and hospital accreditation. So that is a formal third-party recognition that our organization is competent to do specific tasks and to do the work that we're accredited to do. So in our sector, we're governed by the Standards Council of Canada. And why do we strive to achieve and maintain accreditation? Well, in the sector where I practice, it's mandatory. So the government has mandated that our hospitals and laboratories have to be accredited. And ISO 15189 plus accreditation is voluntary, but it is desired by many organizations to demonstrate that you meet internationally prescribed standards, not just your locally regulated standards. And so what does accreditation involve? It involves a rigorous review by external accrediting bodies. And accreditation for laboratory hematology in our sector is quite complex. We have quite a few people that are involved in the accreditation of our activities. So Accreditation Canada Diagnostics accredits all laboratory disciplines, so hematology is part of that. But we also have accreditation that is separate for transfusion medicine parts of our laboratory, for our stem cell laboratory, and for our HLA laboratory, we have ASHI accreditation involved in our process. So what does that mean in practice? We always have something going on related to our accreditation cycle, and this is a diagram of a typical 4-year cycle where we have activities going on all the time to accredit different parts of our laboratory organization. So an accreditation audit is really something that plays an important role in promoting quality. It's a planned, independent, and documented assessment, and its goal is to determine whether the agreed upon quality requirements that apply to your jurisdiction are being met. And for ISO 15189, what does the accreditation require? It requires that all activities occurring in labs, including pre-examination, so things like sample procurement, examination, and post-examination phases are being conducted in a manner that meets the needs and requirements of the users, as well as conforming to standards. So that type of accreditation asks questions about whether processes are well implemented, are they effective in achieving their purposes, and are they well maintained? And so they're looking at the documented records of what you do in order to answer those questions. Audits include both external and internal audits. External audits are performed by the outside regulatory or certifying bodies or agencies. So in Canada, that's by organizations such as Accreditation Canada Diagnostics or ASHI. These audits ensure that a lab is complying to the standards that have been set by the organizations, by government statutes, and other regulations that pertain to where you practice. Internal audits are performed by an organization to look at its own systems and procedures, and they ensure that maintenance, development, and improvement of processes is happening on an ongoing basis. So there are some differences between internal and external audits. External audits can be quite time consuming. They can sometimes go on for a full week. They'll cover all of the requirements of accreditation. They typically have multiple assessors in order to be able to cover all disciplines and sites. And many have dedicated assessors for individual disciplines or sections, and non-conformances are typically in external audits rated as major or minor. When you do an internal audit, that depends on the number of labs and the number of assessors that you have available. We typically cover fewer requirements and focus on only certain sections or disciplines. We may want to focus on items that were viewed as a major or a minor non-conformance on a previous external audit. Typically have fewer assessors. Those assessors may be assigned to more than one discipline. And we don't rate the non-conformances. We're looking for opportunities for improvement and tracking those in preparation for an external audit that may be coming up. So why do we do this? It's a requirement, so we have to do it. And if you look at accreditation bodies like Accreditation Canada Diagnostics or ISO 15189 requirements, you have to do internal audits. And in order to be successful in external audits, you really need to have an internal audit to prepare you. So they allow us to look at our organization and how we do things, and make sure that we're doing things that are adequate, well implemented, and effective. So internal audits help you mitigate and reduce risk. That's important for discovering your non-conformances, connecting in your organization to improve them, and working on issues that impact on safety. So what about risk management in all of this? It's an important thing to consider as part of your quality management system. What is risk? How is it assessed? What are the accreditation requirements for assessment of risk? So I'm going to touch on how we manage our resources and tools, provide some risk examples and risk considerations for laboratory medicine. So you can define risk in a number of ways. The dictionary defines it as a situation that involves exposure to danger and something unpleasant may happen. The ISO standards talk about risk being an effect of uncertainty on your objectives, and the combination of probability and frequency for the occurrence of harm and the severity of that harm are important concepts to think about when you think about risk. So how do we assess risk in a laboratory program? There are tools that have been developed to support decisions in risk management. And that's a way of seeking answers to the key question of what can go wrong, what kind of errors can happen, how likely are those particular errors going to occur, and what are the consequences or the harm associated with such errors. Risk management is a way of analyzing, evaluating, controlling, and monitoring risks. To look at what process need risk mitigation, what can be done to control, avoid, minimize, or eliminate unacceptable risks, and action plan and follow-up. So the overall goal is to identify, assess, prioritize, then manage with the goal of reducing risk. Assessing risk in the laboratory requires us to consider all instruments and methods. It can be subjected to pre-analytical, analytical, or post-analytical failures or risks. And those can affect the accuracy, reliability, and the impact of results. And several factors impact on the importance, the severity, and probability of risks. So what device or method design you have in place, who's the user, what's the operating environment that aspect of your testing is working in. Lab professionals have to consider risk during test development and ensure that the most effective and efficient QA, QC programs are set up to mitigate risk once a test is implemented. And I refer you to CLSI documents for further information on this. So this is an example of an Accreditation Canada requirement related to our quality management system and risk management, that we're required that it be utilized to evaluate the impact of work processes and potential failures on results that affect patient safety, and that we modify our processes to reduce or eliminate risks, and they refer to the ISO 15189 standard and clause for this. And so in their accreditation, they indicate what the assessors need to look for and the explanation for why. And we, on a previous accreditation visit, had a non-conformance related to these standards, that the assessors felt that our laboratory had not used risk assessment to evaluate the impact of work processes on potential failures on examination result as they affect patient safety and pathology. So when we got that message, we then had to take action to solve this, not meeting that aspect of a mandatory requirement. So how do you go about doing that? Our quality management system has guiding documents for our laboratories on risk assessment. They're available to people that work in our environment on our quality management software resources. And we also point people towards other resources that are available. There are a number of resource tools now available for doing risk assessments, and I want to touch on some of these. They're covered in CLSI documents. There's the FMEA, the failure mode and effects analysis, that we found useful in our organization for doing a bottom-up approach to look at our processes and ask what can go wrong and score it. There are fault tree analysis. We typically also use FRACIS, failure reporting analysis and corrective action systems, to deal with some errors. If you've got a good way of capturing a rate of observed failures, then you can look at putting in control measures and then looking at whether or not your failure rates improve. And I'll give you an example of that. And there's the Pareto analysis tool that some organizations use as well. So I want to give you now a practical example of doing a risk assessment. So a number of years ago, our genetics lab looked at their whole processes for risk assessment, and they wanted to create and implement action plans to mitigate risks. So they looked at the entire laboratory workflow, created 21 process maps, scored 215 process steps, and then looked at ideas for improvement and used the FMEA tool. And I'll give you some more details on that as we go through this. So that was a structured approach aimed at identifying possible failures and looking at how severe or significant they could be, with an effects analysis of the consequences. So the major steps in doing this are map your processes, identify all failure modes that may happen, assign a number for the severity, probability of the occurrence, and the likelihood of detecting it. So something's more risky if you don't detect that an error is occurring. And then to calculate an overall risk priority number. So these are some of the process maps that the genetic service put together. We send the genetic service blood and bone marrow that is cultured for doing things like looking at cytogenetic changes in diseases. So they went through those maps. They also looked at procedures such as their BRCA library preparation process. And then took the data for each of the processes and assigned numerical values using scales. So 3 things get rated: the severity of a particular failure, if it occurs, what degree of harm will likely occur, what's the probability of occurrence, and the likelihood of detection. And then you end up calculating an overall risk priority number for each of these elements by multiplying the S, the O, and the D scores to get your number. So a higher number means a higher risk. And so this can help you prioritize if you can't tackle dealing with the risk for each of everything that you've identified as a risk at the same time. And so in the FMEA score, these are the ways that you score. So you can see under severity, probability of recurrence, likelihood of detection, there's a standard way to decide what score you should assign to each of the things that you're looking at. So when the genetics group did this, they identified one thing that had the highest score, which was a critical sample arriving without notification. And you can imagine this would also be something that would be very risky to a hematology laboratory. The other thing that had a fairly high score was a sample never arriving. So a sample could be of low priority, high priority if it never arrived in the lab. That turned out to something that had a high risk priority number. So they decided to tackle the highest number thing first. So that can be helpful for setting directions and creating an action plan. And then post-implementation, you may need to recalculate what your risk priority number is to show what degree of risk reduction you've managed to achieve. So important to discuss and review the charts from such an assessment as part of using the tool. They also worked on looking at other opportunities for improvement, not necessarily tied to the things that had the highest priority numbers. And there you see that staff in the lab worked on tackling different things for further quality improvement. So outcomes, putting into plans of action to address your highest scores. Often this in laboratories is a push to automate things, to reduce manual processing steps because they're more prone to having errors occur. So these are some examples of the sort of things that you can do to reduce manual processing steps. And then as part of the final part of closing the loop is a change to practice memo being distributed so that people know what changes are being made to reduce risk. So what about risk reduction considerations? What we've learned is that FEMA is helpful to use before a test process change or a new test process is implemented in a laboratory. We've learned over the years that our manual processing steps are where we have the highest chance for error, and that our entire laboratory workflow, the pre-analytical, analytical, and post-analytical needs to be considered when we're doing risks assessments. So what about quality support for specific initiatives? I've had a very busy last year involved in a major project to update our coagulation instrument and assays across our multiple site laboratory programs. So we have a centralized lab program that supports the academic hospitals in our organization. And so this started with the quality system helping us with developing a request for proposal from vendors, assembly of a project team with standardized scoring to look at what the vendors were offering, and to also have a project team for the implementation component. And we consider quality improvements and implemented them at multiple steps. So our solution had to have quality considerations in deciding what was the best choice. The implementation, we had to do the usual assay validation verification, but we also at the same time coordinated a complete overhaul of interpretive comments, considered best practice and guidance recommendations and improvements for each of our tests, and undertook some new approaches to reporting based on risk considerations. We had to update some critical values. We made new occurrence of a specific inhibitor against a coagulation factor. We made that a critical value, which is something we hadn't done before. We're implementing new technologies with new opportunities for improvement. So we've gone to using equipment with automated pre-analytical checks in order to reduce errors and risks. And we've updated methods and reporting to be consistent with new guidelines. So the risk management and risk assessment was something that we really had to consider in communicating our requirements to vendors. There were minimum requirements that they had to meet in order to look at what would be an appropriate solution. Accreditation requirements were also considered, that the way an instrument records information had to meet the expectations of the people who are accrediting our laboratory. And risk reduction measures, one important thing is to do the reference range validation, linearity checks, quality control assessments that you need to do as part of a switchover. But we also looked at things like pediatric results. Few laboratories have the resources to establish their own pediatric reference ranges for all of their assays. And we considered the pitfalls of releasing a result without a reference range would mean that an abnormality is not flagged. So a service may overlook an important finding such as mild hemophilia. And in doing audits as part of our switchover, we saw that indeed that does happen. So we put in solutions to deal with this. So switch to new methods that have published reference intervals for children that now auto-attach to results. The other thing we did is we looked at some things where we don't do an interpretation on the fly, like when we do coagulation tests with mixing studies. So we looked at ways of offering an interpretation in a standard way that could be helpful, practical, and efficient. And I'll show you what we did with that. For the pre-analytical, our underfilled coagulation tubes are now being evaluated on the instrument. And we've discovered after we went live that we've got 4 to 10% of our coag samples coming in underfilled from our hospitals. That's not acceptable. You can have falsely low values for D-dimers. You can have artificially prolonged coagulation tests if you underfill a tube. So we're moving now to corrective measures. So this is an example of what we did for reporting pediatric factor levels. We had a consensus approach to decide on what numerical values we would attach to different age groups based on published data that's out there. So not exactly the same time frame looked at in each of the studies. So we used consensus to decide what numbers we would actually attach. And we now report data with a source of those reference values included as a comment on results that have an attached reference interval for children. And so this is an example of how that appears on a patient's report for factor 9. So we give an age-specific reference interval, and we indicate the source of the reference values by PubMed identifier numbers. And also we auto-attach a comment that if we have a patient who's on pegylated factor 9, this isn't the appropriate test for such patients. We've also looked at how do we approach coagulation assays for which we don't have any published data to attach a reference interval for. So an example of that is our antithrombin immunoassay. And so what we did was come up with a comment to guide people on how to interpret what the value might mean. We give them the adult reference interval. We state that it has a similar lower limit to the functional assay that we do, and give them a reference to the literature to look at functional antithrombin levels in children if they're trying to decide if the result is normal or represents a type 1 or type 2 deficiency. For D-dimers, we did an important update to the way we report them. So we decided as a quality improvement to include information specific for the assay that we were implementing. So now we release results below the cutoff of D-dimer levels for children that are 16 and over, and for adults, they have the same comment attached. And that was done in collaboration with our thrombosis service. So we indicate that values below that cutoff in outpatients with low or moderate pretest probabilities have a high negative predictive value for acute thrombosis. And if the person is older, we also provide information on using an age-adjusted cutoff, that is the D-dimer value of 10 times the patient's age. So if you're 60, that would be 600, and cite the literature for that to try and improve the quality of what people are doing with the D-dimer results that our lab is reporting. Now, we also considered children in this. And we've taken a new approach. We used to auto-attach a standard comment to children and adult results about the cutoff for DVT-PE exclusion. But we've taken a different approach now for reporting pediatric results. And why did we do that? It's because the D-dimer is not validated for VTE exclusion in children. So the comments for adults wouldn't be appropriate to attach to a child's result. And the other reason why we're reporting age-specific reference intervals is that kids actually have a D-dimer level that's higher than adults until puberty. So if people are trying to look at this child and whether or not the D-dimer is evident of DIC, having an age-specific reference interval attached is really important. And we've given, as our now standard approach, a citation for where we got that reference value from if we didn't determine it in our lab. This is the example of what we decided to do for one-to-one mixing studies. We don't have a hematologist on call to report these on the fly. So we put in a standard comment that we think covers the basis for how you need to interpret a mixing study. And we're hoping that having this data there will discourage people from ordering a mixing study when it's not appropriate, such as when there's a less than 5-second prolongation in the test, because those values on a mixing study, if they're minimally prolonged, will always correct on the mixing study. And we're indicating that if it is significantly prolonged, well, what could be the cause? There could be a number of reasons for that. So telling people that they should be correlating it with the clinical and drug history and consider further investigations if appropriate. Now, the other thing we've done for quality improvement, and this is a memo that we sent out yesterday, is to address the common pre-analytical problem of underfilling coagulation tubes. So this is the actual memo that went out. We told people that they must fill coagulation tubes 90 to 100%. And why is that? Because if you underfill it, you have excess calcium chelation, so coagulation clot-based tests will be falsely prolonged, but you're also going to have falsely low levels of coagulation proteins. So if you're doing a D-dimer for VTE exclusion, you won't get an accurate result. If you're measuring an anticoagulant level, you won't get an accurate result. And we gave them the data for our different sites, how bad their current pre-analytical performance is, that we have a high percentage of coagulation tubes that we're now rejecting because they're underfilled. And We've asked people for their help to address the root cause. So this is an example of communication and collaboration going beyond the laboratory to try and address pre-analytical problems. We also included a citation from a site that reported achieving less than 1% underfilled tubes by implementing educational errors. So common reasons: people are using tubes that are outdated. They're not using a butterfly collection set without a discard tube. So we're hoping that having implemented this measure, we will get to a much lower and more acceptable rate of coagulation tube rejection based on underfilling. So I want to end with an inspirational quote. Quality is something that we need to think about every day in medical care services and in the laboratory. So this is a quote from Bill Gates. "We know that quality and safety occupy a prominent place in the strategic plans of many healthcare organizations. However, a common organizational response to the emphasis on quality and safety is a long list of worthwhile projects and measures that aren't well coordinated, let alone capable of achieving system level results." You have to have the will to improve. You have to have ideas about alternatives to the status quo. And when you have to execute these ideas reliably and robustly to make changes real and sustainable. So I want to end with an image of the beautiful city in Italy, Bologna, where we will be having the 35th ISLH meeting later this year. And I would be honored if we had people from PSH join us in person or online in this important activity of our organization. It has been such a pleasure to participate in your meeting, and I look forward to your participation in ours. Thank you so much.
Thank you so much, Catherine. That was an excellent talk. And thank you so much for making us understand how important quality assurance is in smooth running of labs for their day-to-day activities. From Pakistan's perspective, labs who are aiming to get international accreditation, what will be your 3 take-home messages to give to us, for especially for people who are getting they're planning to get their labs accredited? What 3 take-home messages are crucial to get the accreditation in technologists or directors who are planning to get their labs accredited?
I think you need a team, you need a framework to set your goals, and I think the team should be enthusiastic to set goals and to see their achievements. There's lots of online resources. If accreditation standards in your country are not developed to the degree that they are in others, Accreditation Canada website, for example, has a lot of things that you can access on their website that I find very helpful in general. But I think working on quality is always a continuous process. You have to start where you are right now and continually work to be better, to better meet patient needs.
Well, thank you so much for that, Catherine. Those are absolute gem of the pointers that you've given us. We greatly appreciate this. In fact, the society immensely appreciates your contributions, and we look forward to your participation next year as well. Thank you so much.
Thank you. It was a pleasure to participate.